I have information that they are prepared in the lab, so we can continue with live cases, and then we will have some coffee break afterwards, because we have really busy agenda today, and we wanted to show you all these available technologies, so everybody can judge which one is better or is worth using. So can we connect to eCam?
Okay. Super, ano, we are ready.
Okay, we can see you and we can hear you as well.
Nice. Here is the camera.
Hi.
Hi.
Please,
yeah, good morning to everyone. We are from eCam, and we start with this procedure on Varipulse with a paroxysmal AFib ablation. Please, another thank you so much. We have a very pretty guy. He is a 50-year-old gentleman. He is a rugby player. That he looks very fine. And he has been diagnosed with paroxysmal atrial fibrillation in November 2023. It's a pure paroxysmal arrhythmia. He had a medication, rivaroxaban and bisoprolol, because he intolerated of propafenone. His comorbidities in April 2024, he had deep venous thrombosis in vena poplitea and vena femoralis right side. But now it's okay. We check it before procedure, and his echo is normal. That we are preparing now to do ablation with PF energy with the system Varipulse. And here is Maximo, and I think he will continue.
Hi, Joseph. Hi, everybody. We already have just finished the left atrial map, anatomical and voltage map. And we have a very, very small left inferior pulmonary vein, and we have a good right inferior pulmonary vein for anatomy. We are ready to do the first application at the ostium of the left superior. As you can see, when the electrodes are switched on the lights, the white lights, that means that we have a good contact. We have not perfect contact on electrodes number 8 and 9, but we will do better when we will do the antral one and when we will rotate. The gap between 1 and 10 is on the roof. So we can give the first application. Every application we give, is we give 3 trains of impulse for this position without moving. Then we will wait a little bit, we will rotate, and we will give the second 3 trains. You see, soon after the first application, the electrograms that were very high completely disappeared.
And you can see clearly 9 contact on echocardiography. It's a view from right ventricle. Here is left superior vein, and we are inside.
Can we switch
please, echo.
The echo, please, can you show the echo?
Yeah, is here already.
Image, can we make it bigger so we can see something?
Bigger eyes image, please.
Yeah, so that's the view I mentioned. You have appendage anterior, and then you have the catheter is sitting, touching posterior wall and touching anteriorly the ridge.
Yes. Joseph, I just rotate around 45 degrees, and now the gap between 1 and 10 is anterior superior, so it's a different position. We can give the second application.
Okay, now we need to see the 3D electron anatomical map. Carto map, please.
Carto? You remember 1 and 10 was supero posterior, now is anterior. And we are at the same deep in the vein. Now it's very easy because I just open the variable circle catheter, and now, as you can see, I'm more antral.
Please echo. Yeah.
So you are rotating posterior
as well?
to cover this posterior part of the...
Yeah.
Perfect.
If you remember the first position.
So you see part of this lasso touching the posterior wall, and there is inferior vein is going in oblique direction. So.
Yeah.
And also on the CARTO screen, 1, 2, 3, 4 are perfectly switched on, so the contact is very good now. As the echo, as Joseph told about with the echo. Please, deliver, go. Okay, so this is the last one now. The last? Okay, perfect. The last one. Now I rotate again 45 degrees, a little bit more. You see, now the gap is posterior superior, but with the larger sides of the catheter. Now the catheter, I'm creating a big catheter just to cover the antrum of the vein.
And we partially covered on the echo left inferior vein too. Yeah, here we can see on the echo.
Okay.
Partially.
As you can see, I don't have a good contact on the carina, but I did the carina very good in the first two applications. In this patient, the carina is a little bit deep, and if I want to touch the carina, I lose the contact on the antrum. So now I do a good application on the antrum. Go. You see the left lateral ridge is very well touched by electrode number 1, 2, 3, 4.
Massimo, with it's Paul Gould here. With the applications, there appears to be quite a few micro bubbles on ice. Is that
Yes.
That's typical?
Yes, that's typical. And I can tell you that in the first wave of the INSPIRE study, we did to all patients the magnetic resonance, and we found no cerebral ischemic silent event. So you're right, there are microbubbles, but we did magnetic cerebral resonance to all our patients in the wave 1, and we never found any finding. So
It's electrolysis.
yes.
Well, it could be also heating. Well, it could be electrolysis. So there's still discussion about.
Yes, for sure, Joseph, for sure. We are studying a lot this topic. I think this is very important also for all new technology arriving. We should pay attention to heating a little bit and also to platelet activation. We are studying platelet activation with a specialist of blood, of course.
So you see, this is inferior vein going then down, and
Okay.
he was placing now the catheter.
Yes, it's very small. I don't want to go in a wrong axis because to do the map, I went into the vein, but I went in a wrong axis with anterior shape too deep when compared to the posterior. Now it's good for me and we can deliver. Go.
Here we can see on echo the very good contact.
Please show the echo, please. To the audience.
Echo.
Echo.
Mm-hmm.
You see the echo, please, Joseph, can you?
Excellent contact. Yeah, we can see it. It looks really good.
Thank you.
Great
Thank
imaging.
You. Thanks to Janka, because I'm not so able with echo, because I don't have money to use it. Okay? 3 application, and then I clockwise rotate, always clockwise. We can't counterclockwise rotate, because this catheter needs to be rotated only in a clockwise manner. Okay. Now I'm in a different position. Okay, go. You remember before the 110 was on the superior shape, now is anterior shape.
Maybe we can switch on CARTO again.
Yes.
Yeah. Into the auditorium, yeah.
One thing that's very obvious, this imaging is excellent for catheter position, both with the ice and with the 3D non-fluoroscopic imaging. It's just really shows the workflow very, very well.
Now I go for the antrum, and for this vein is so small, the antrum is important as well.
How many ablations do you typically do for the antrum?
2. 2 at the ostium and 2 at the antrum. Typically we do 4 ablations for each vein. Okay, you can go. If you see the left side carto, we are much more external than the previous application.
Yeah. And was more sharper signals here. That it's really clearly.
Yes.
Yeah. Now, in the review.
You see now the loop is 35 millimeters. We are outside vein. Okay, I rotate a little bit more, and then we do the last application here. I'm rotating just to change the position of the gap. Okay. Now the gap is posterior. Okay, I can go again on the vein.
Yeah. You are near to the right. Yes.
Let me see.
Yes, of course.
Because this vein is very small.
Yeah, and very close to.
Okay, we can go.
So it's a posterior part of this antrum.
Yes. Yes.
Looks the
And
atrium is
also-
not very big. When you
not
sleep outside, you are almost in the right inferior
Yes.
vein.
Yeah,
Yes.
Well, I saw an intracardiac echo.
yeah. It's here. It's clearly here. We can see.
Posterior anterior view on the right, please enter posterior on the left. Now we close the loop of the, and we go
Yes.
to the right inferior.
Yes, on echo we can see.
If we see the map, we have 1 centimeter and a half distance
Yeah.
from the previous application.
So
And
this
now
is
we are-
posterior wall.
Yes,
My experience with this technology is once you really maximally close the circle, it becomes stiffer, sometimes more difficult to manipulate inside the osteum, like inferior vein.
but we are lucky, Joseph, because this vein inferior is enough huge.
Yeah, this one
Yeah,
is
you
not
can
We're
see on
lucky.
echo. Yeah.
Yeah, but if the vein is
Okay,
flat,
go.
sometimes it's difficult because you get a much stiffer device when you close the circle. And then you have also the problem with overlapping, so you have to switch off some of these electrodes during application.
So there's no clash. Is it easy to do, to judge which ones to turn
No,
off?
yeah, you see which one is touching, so you switch them off, and then you can. It's not automatic. But
It's not automatic. Is there feedback from the ablator with
Yeah, yeah.
impedance? That
no,
would
yeah,
tell
you see on
It's only visual.
which one is
Okay,
touching.
go. We do, I change the 110 position, and I give 2 more. To the
See, this is now touching the inferior part
Yeah.
of this antrum.
No, this is the ostium.
It looks good.
Now we go a
catheter
little bit
position.
more out. We are inside. Okay. Now I open. Of course, when the right inferior vein is flat, is small, it is a little bit more difficult. Now I I push the long sheet in order to pull back a little bit the catheter, and I go out. I open the circle. Okay, now I'm outside. You see?
Maybe with the
You see?
some
Yep.
plane.
Yes, we can.
Okay.
That's excellent catheter position.
Okay,
it's well
go.
demonstrated.
Go. We are a little bit more out. Yeah, we are in the antrum.
Yep.
When the atrium is very small, in this case, the transeptal puncture was done a little bit anterior on the fossa valis, and so we have more room to rotate from the fossa valis to right inferior. So it is easy to go here. It's easier when you have transeptal puncture a little bit more anterior.
And transeptal sheath is 8.5 French?
That's a visible.
transeptal-
Visigo? Yeah,
Yes,
it's,
visigo,
8.5
visigo.
French.
Yes, it is.
Narrow bore.
That's the
think,
beauty of ice-guided transeptal puncture. They can do puncture where you want. You can go anterior,
Yes.
you can go
Yes, you are
inferior, posterior, depending on what you want
Okay,
to
go.
do.
I changed the 110 position and give it the last one here.
Massimo, I was interested to hear you can only clock the catheter. I have no experience with this. Have you ever
Yes.
counterclocked it accidentally? What happens?
If you are in the left atrium, nothing. If you are in the appendage or close to the valve, you go like a screw, because this catheter, you can only clockwise rotate, because if you do counterclock.
Now we cover very nice the ostium. Okay.
Yes, now we are going to the right superior.
Lovely.
Because we did 4.
Now
We
you
did
are
4 and I go to the right
in
superior.
the area between the both veins.
Beautiful ice views of the catheter.
Yeah, from left.
Let me see here.
Nice.
The echo.
Yeah,
Okay.
yeah, okay.
Now left on the anteroposterior, please, Peter. I was. Peter, left
Peter.
side on the anteroposterior, because I prefer. Okay, now it's perfect, because in this way I can understand how deep I am in the vein. You see?
Yeah.
The right inferior is very big. Eh? Okay, now we are.
No, we are not inside. I try to find a better.
It is a little bit small. In this patient, is the right superior is smaller than inferior. Huh?
Yeah, it's because of because of position of the heart. So sometimes in young
Yes.
people,
Yes.
superior vein is really anterior. So
Yes.
you have to rotate
Yes,
more.
now we are here. You can see on the echo.
Is good for you, Janka?
Yeah, I think it's good.
Okay, we can go. I always
It
ask
should be-
to.
Echo guidance.
Yeah. I say, I have this lucky. I have to take the maximum advantage.
I can move to Italy. You have a good wine here.
Okay. Now we are very, very close.
You have to go
Perfect.
probably higher.
Go.
Yes, you know.
Go. I rotate and now you can go. We gave 1 milligram of atropine before the left superior, because the heart rate of a patient was 50, 55 beats per minute. So in order to avoid vagal reflex, we gave just 1 milligram before left superior. Huh?
Can I add CT?
Now I open, because I gave 2. I open, I just pull back a little bit. One of the risks in right superior is to go out of axis. Now the axis is perfect. Okay, you can go. Because sometimes the electrode number 1, 2, 3 go inside the vein, and the electrode 7, 8, 9 are outside, and we go in the vein completely out of axis. So this is the only thing to pay attention to get a better ablation. Okay, I rotate. Okay, you can go. And, okay. Now I had a little bit of phrenic activation with diaphragm contraction, because now electrode number 9 is close to the phrenic nerve. Again, phrenic nerve activation. But we don't have any kind of concern about it. Okay, we finish. Now we can remap if you want.
So you have about 5 more minutes.
We can do the remap. Or if you want, we can wait and do the remap after waiting period, as you prefer.
Well, if you
Left side
you
we
can
can.
do map now, because
Okay.
then
Okay.
then
Okay, I
basically
start.
you're done.
Yeah,
Okay.
excellent. Very good.
So we will then switch to Homolka for next case.
So we are in the left superior now.
Yeah, yes. It's some signals here. Maybe we can paste
No,
from
these
this.
signals
of
are
course.
smooth and
Yes,
are
it's
from
maybe from
appendage.
appendage, yeah. Yes, for
Are
this.
only on the
Yeah.
anterior shape.
Yeah.
Only from the anterior shape. To reduce these signals, I strongly suggest to put the high pass filter to 100 Hz. Because if we put a 100 filter to 100 Hertz, we reduce the smooth signals and we will cut the appendage far field. Okay, left superior is perfect.
Can we see the map maybe? Oh. Okay.
Left inferior, Joseph, is very small. We can only enter by side,
Yeah.
not because it's very small. The catheter now is 25, it's close at the maximum, but the vein you see is very, very small. Now we are at the ostium of the vein, and we don't have anything. You can see do you have the electrogram intracardiac signals?
Yes, we can see those.
Can you show the intracardiac signals, please, to the audience?
Yeah, we see them.
It's clear, it's good.
Okay, perfect. Now I move to the right pulmonary vein. Please keep the left side on the anteroposterior always. Okay, thank you. This is the right superior.
There's nothing.
Clear.
It's clear. I go to the antrum because, of course, we did the antrum as well. I open and it's clear also the antrum. Now I go to the right inferior, sorry. And we are in the right inferior and I have, can we pace from 9-10 please? No, but it is on the bottom. No, it is on the bottom. No capture. No, it's okay, it's okay. It is a bottom far field. Okay, perfect. I finished, Joseph. Do you want something else?
Can I have a question?
Yes.
Yes, we have a really small area on the posterior wall. In this case, if you have a small atrium, do you prefer to continue with this posterior wall ablation, or is just okay?
No.
It's not the place for some supraventricular tachycardia from atrial tachycardia from this area, posterior wall? Okay. Thank you.
Any questions from the floor?
But it's right.
Comments?
I prefer to avoid because you can recover this area after.
Okay. Yes, okay.
There's one question.
Yes?
Can you use microphone? You have to follow who is asking for question.
Exercise, I mean, just, all the time, just, sitting over there. Massimo, this is Claudio. A great procedure. Just one question. Why you like just to give, atropine to the patient? I like to have a vagal reaction, actually.
Yes, because this patient started at 50 beats per minute. Sometimes I had 10-15 seconds of sinus arrest or usually sinus arrest. So in order to prevent, I give atropine just for this. Because in my lab, I don't use other catheters. I just use this one. And I don't have a backup catheter. So when the patient starts it's a bradycardic patient, I prefer. But honestly, when I have this kind of patients, I prefer the Q dot. Because when a patient is a bradycardic patient, I also do usually a neuromodulation because, these increase the success rate. In this case, the bradycardia was related.
Massimo, it's not yet proved that you increase success rate. You increase the heart rate. That's proved.
Yes.
And it might be for some of these sporty guys might be detrimental because they feel if you have increased by 10, they can feel it, that they can complain even. We have one patient like that, he's complaining all the time.
What I do only, I don't do the right side, I do only, of course, in the left, on the roof of the left superior and under the roof of the right superior. We don't increase so much, and this is good for patients that do also pauses at the AF interruption. Of course, if you have an healthy man with 50 beats per minute because he is a runner, of course we don't. Of course, you are right.
Okay, so is there anything you want to add for your procedure? Because it looks that you've done everything and you finish in time.
Next, thank you.
It was quickly,
Thank you very much
you
for
so
a nice demonstration, for
you.
making it within 20 minutes, all this case. And we will move to Homolka. Thanks a lot.
Congratulations.
Thank you
Great
so
job.
much.
Thank you.
Well done.
Bye.
Thank you. Thank you.
Petre?
Hello, guys. Yeah, Peppo.
Morning,
We
Peppo.
can hear you.
Actually,
So
yeah,
the
Please.
floor is yours.
nice. Okay, so you know what? During the faculty dinner yesterday, Fermin complained that I didn't name you Peppo. Okay, so I will name you Peppa, Peppo. Okay, he will be happy. Okay, so guys, we have a 52 years old guy who looks like 42 years old, and actually he's with paroxysmal atrial fibrillation, and we were asked to replace, or I was asked to replace Atul Verma, who is like, I mean, mentor for Pulse Select technology. So we will show you the Pulse Select technology for the paroxysmal atrial fibrillation patient. So we just map with Octare, so we use Kato. We use Kato for mapping of left atrium. We have Octare map, which is really, I really like it. I'm not promoter, but I really like it. And we integrate the Pulse Select catheter to the electroanalytical map. So we have now, you can see the catheter somewhere in the body of the left atrium. What I really tried to make you happy, Peppo, that we did ICE catheter. And Toshi Toshi is here, Ken is here, Pavel is here. So we have paroxysmal atrial fibrillation patient with 4 operators. Maybe they will join us as well. So we'll be like a really strong group here. And I must admit that it's our 3rd patient with Pulse Select. I did first my patients Saturday to train, to run in. So it's like my 3rd patient. And Ken Kakita from Japan, from Kyoto, he is highly experienced with Pulse Select patients, so he did over 100 patients. So Toshi will show you how we manipulate with the catheter, with the ICE catheter in the left atrium. So, because you know, as we mentioned, actually, Fermin has a very nice presentation yesterday about the ICE, and actually ICE is in left atrium, could be for the pulse field technology now coming standard, okay? So you can see that we have in left superior vein, we have a wire, and over the wire, because the catheter, I'm a Pulse Select catheter, I know I need to admit it's not like PVAC catheter, but it was original PVAC catheter. It's over the wire catheter. And so we have now in the shape of horseshoe, okay? So we need to move, and actually Toshi is moving the catheter towards upper left vein in the full ring. So it's like, well, it's very important to manipulate with full ring catheter. And you can see visualization on the cathode, okay? So we are a little still part, and we are a little bit more inside of the vein than we need to be. But actually, I think we can start a little bit even deeper, because it's our pulse field. We can prove that we have any risk for stenosis, PV stenosis. So usually the strategy with this 1,500 volt pulse, we are pulsing 4 cycles during, like, I'm synchronized on the QRS, and usually we do like 2 applications per position. Okay, so we are probably ready now for the first application. Actually, look at the eyes. We can be focused on the eyes for the bubble and the microbubble formation. And now, please, we can charge the system. And we are ready for, actually, we have anesthesia, I didn't mention, so we have anesthesia, and now it's pulsing. Now we will be pulsing. We need to synchronize with technicians for controlling the cato, because cato needs to be switched off to protect any shifts. So please, yes, go for application. So now it will be one pulse, second pulse, third pulse, and last pulse. Okay, done. And actually, we do one more in the same location, okay? 1, 2, 3, 4. And now we will move it catheter, okay? So actually, well, we have a max ring. So actually now I will try to follow the catheter and rotate a bit, rotate, and actually it's fine. So like over 90 degrees rotation, and go shadow, and we are ready for the second series of pulses. Usually, I mentioned that we apply 8 applications per the ostium, per the side. And I don't want to be that deep. So after this, so we will, specifically for superior veins, I really want to get more bonus lesions on the anterior part, because actually comparing different technology, and Pepa mentioned yesterday that we are really striking in the Czechia, because to be the most experience in the pulse field, comparing the nations. So it's very, very nice. Okay, so now we are ready for another rotation. I would not rotate too much, because it was too much, maybe. Fine. Okay, it's like perfect.
Peter, with the rotations, we're seeing some signals go by. You're searching for the signals?
I'm always looking at the signals, and I'm trying now to be a little bit more out, okay? And
we see signals now.
yes. Okay, because I'm a little bit outer, okay? The shade is okay. So we can control by sheet. Actually, well, Atul during the presentation mentioned the deflection of the catheter, but I never use it. I'm like sheeting guy, so I'm using the sheets for deflection. Okay. If you look at the floor, okay, so you see that it's really okay positioning. On the catheter is a little bit
basically covering
outer,
part of
and
the
now
inferior
I'm a
vein
little more
also.
posterior, which I want to be. Okay. Oh no! Now I jump
in
inside.
there, yeah.
Now jump inside.
Yep.
Sorry. Go back. Okay. Okay. Now. Okay. So let's go now. Okay. Save it. Shadow, please. Switch off the magnet and let's go. So this third series of applications. And if you look at the eyes, it's a really nice visualization. Actually, Peppo, I think that we discussed yesterday during the dinner a lot about the eyes. And actually, I think that it might be good standard for the applications of the PFA technology to go to left atrium with because the sheets are a little bit bigger and it's easy to follow the virus, so we can just be there easily. Okay. Okay.
If you see it from right,
no too much potential.
you don't need to go to left, but I agree that if you don't see it, you can improve visualization if you go to the left. It's not
and I don't want to go too much posterior, because I really want to stay with this paroxysmal patient. I don't want to cover more, because I don't want to finish or end up the procedure with narrow channel on the posterior. Okay, let's go for the last applications. Okay, please. And then I will try to get the visualization for the anterior side, okay? So we try to get more anterior on the close to the ridge of left upper vein. But no, Peppo, I think that somebody mentioned the potentials. I am not looking at the potentials. Okay, if I see the potentials, fine. But if I don't see the potentials, it's not the end point. Okay.
It's anatomically driven.
Yes. But no. I mean, I'm speaking about if you are, because if you have no potential after several applications, you still can have some like stunning or something. So I really don't care about.
Yes, but if you have potentials after application,
No, yeah,
that's
if
not
you have,
good.
this
So
is the different story. But
potentials are
if you have
important.
it's okay. So now let's try to get, okay. So I will go more. Okay. Now it's go. Perfect. Nice.
Now you have nice potentials.
Okay. And I have different, okay. Give me top roof on the right side, Martin. Give me top down. Okay. Okay, let's go. The bonus lesions here, please. Okay. And for sure, we will map out after this procedure.
And just
Maybe
one thing.
even
Sorry.
No,
Just
please.
one thing with this ICE view, we are in the left atrium, but I just flipped the ICE probe like a supramitral view to look at the superior vein right here. You see the appendage and reach the same view here.
Yes. It's
So we
perfect.
are
Yes.
just sitting on the
Correct.
reach, almost on the edge of the ridge here.
This is rich appendage.
Yes.
invasion.
It's very
Reach
nice.
appendage view.
Okay, now we are sitting on the ridge. So look, I moved the catheter. Now we are clearly sitting on the ridge. Okay, but I don't want to put any. Okay, let's go. Last bonus. Okay, let's go, guys. Okay, shadow last application. But it's a good position, I think. And let's move to left inferior then. Go pulsing. Okay. Actually, I don't care about duration of the procedure. Now we are really trained to be fast, but actually I still don't want to see the patient second time or third time on the table, which is devastating our workflow. And I didn't mention something about the sheeting, so we need to be careful with this sheet. As Atul explained you, we have, you can focus with the camera on the side part of the sheet, okay? It's a little bit kinking effect. So I think the company needs to improve the sheet because actually I have a third patient and the third kinking, okay? So I'm not too much happy about this. Could cause any like troubles with the bubbles and whatever. So
Does it block off, kink off?
it's like
Yeah,
kinking, yes. Okay, so now let's try to get, okay, perfect, okay. Okay, so I'm going till down. Okay, perfect. Okay, go with wire. Let's target. Okay, perfect. Okay, it's going there.
Should be more posterior.
Okay. Deflecting now, coming. Is that
On
right?
the vein, yes.
Okay, perfect. So again, it's osteo, but I don't care like too much osteo. But actually, right, left inferior. I'm speaking of the right. So all inferiors, like right and left, I am not too much wondering about osteo-antral. But the bonus lesions for both uppers, I really want to get with any technology. Okay. So we are ready for pulsing. So shadow, please. Again, same strategy, 2 pulses per, okay, perfect, per side, per position. Okay, nice. Any comments, guys, or something?
You can
like,
use a wire to anchor more this tool in
Peppo,
osteum.
I would like to show something in the end with anchoring, okay?
Yeah, but there is a wire.
No, because I'm too deep with this, so I don't care too much.
Peter,
okay?
what's the experience of the operators with this technology?
What do you mean about experience?
How many cases?
This is my third case, okay?
Wow, so live a learning curve.
1, 2, 3, okay? So because Peppa asked me to replace Atul and Vivek is in different rooms, so I really and he's doing more cases. I think
This is
he did
excellent.
some cases. Okay, and actually we need to mention that. Okay, did I rotate? Okay.
Peter, you have about 5 minutes, and then
And
we
that's
have
perfect.
to move
Okay,
to
go,
split.
go, go. Okay, let's
Okay,
apply.
so-
You know what? I need to mention that actually Pulse Select was the first PFA technology FDA approved in US. Okay, you need to consider that.
For both paroxysmal and persistent.
And then persistent.
And
First
persistent.
paroxysmal. You can appreciate no signals, but still, no signals. I don't care no signals, okay? I really really want to cover the field. And do you have time, or do you have so we will finish this events and then
You
can
have
we go back
three,
here?
4 minutes more.
Okay,
now.
fine. So we will move to, after that we will move to right. So we'll show you the right super. But actually in the end of the live session, we like really to show you, the map and actually the anchoring principle.
We can come back to you at the end
Yes? Okay,
after,
let's go,
after
let's go,
split.
let's continue.
very well.
Guys.
Presentation.
Don't wait for these things, okay? Perfect, okay. Nice. It's like boring, okay? So maybe it's like,
You're never boring.
no, I'm never boring. Oh, Peppo, I was in TV today, the studio, and actually they say hello, and actually they asked me if this conference is it for public. I said, no, it's not for public. It's for experts for catheter ablation. So actually, I must say that we have very good headlines yesterday and today. So I think we are appreciated to change the word here. Okay, rotation. Perfect. Okay, let's go. I like this more. Okay, go. Shadow. Okay, perfect. Okay, so now we are ready to move. We have 8. Yes, perfect. Okay, so let's move to right upper. One more. Yes, yeah, I know. Okay, for changing the position, I will always using the horseshoe. The horseshoe shape. Okay, done. Yes. That's good. Perfect. Okay. Toshi, let's move the wire, please. Wire out of. Perfect. We are there. Now go.
Why is it?
Yes.
Looks
No,
like
wire is bad work.
you're
Okay?
more in
No, please.
inferior.
Okay, can you? Okay, nice. Perfect. Okay, and go. Perfect. Nice. Okay. So what is the? I'm not able to go too much more. Okay. And this. Can I do this? Okay. So we are a little bit opening, but I will survive. So we will try. Okay. Let's go for a bigger vein. So go, and we can cover the carina. Okay. Okay. So, as I mentioned, upper veins are more, for me, more alarming for getting the gaps. So I really want to get better, more bonus lesions. But actually, always is good to minimize. Actually, all these technologies, I think that we are looking at how to be efficient, but with minimal applications. Okay, so to get this optimal dosing and optimal application. Okay, perfect.
Okay, Peter, we will move to split for another case, and we come back to you at the end of this session,
perfect.
okay?
Okay, perfect. Thank you.
Thanks
you
a
guys.
lot.
Okay,
Thank you.
See you back, okay? Fine.
So can we connect to split, please?
Hi, Professor Kastner.
Yeah, we can.
Hi, everybody.
We can see you. We can
Everybody
hear
from
you.
Split?
Hopefully. So
Good.
you can start the procedure. Or you can show us what you have.
We will. I let Tony give you a short introduction to the case, and then we proceed with the ablation. Tony, please.
Hi. So just let me first tell you about the patient, and then I will tell you what we have done recently. So can I get the first slide, please? Okay. Okay, so it's a 62 years old gentleman. He was hospitalized due to symptoms of heart failure in November last year. It was cardiomyopathy with mildly reduced ejection fraction and atrial fibrillation, and probably tachycardiomyopathy due to persistent atrial fibrillation. He was discharged on rate control and oral anticoagulant therapy. In February this year, we did the transesophageal echo. We ruled out left atrial thrombus, and the cardioversion was performed. And after that, there was improvement of left ventricular ejection fraction, and the patient was clinically better with some moderate mitral regurgitation, so definitely proving tachycardiomyopathy. His echo parameters are slightly enlarged left atrium, 4.2 centimeters, SLAVI 29, and otherwise without other comorbidities, healthy lifestyles. And he's very motivated for the procedure because he returned from the USA and he's planning to live here on the island, so he wants to be arrhythmia-free as much as possible.
It's a nice plan for living.
So,
very lucky he comes back from the US to get the technology.
Yeah, excellent.
That's the end of the case.
So he's considered for the burst IF protocol, and he was enrolled. He's currently in general anesthesia. We did the mapping with IntelliMap Orion catheter using Opal HDX system. And as you can see, there is a single groin access and a single transeptal. We did also CT scan before, which was mandatory according to the study protocol. We see typical PVI anatomy. We've been able to distinguish the thickness of the left atrial muscle, which is 2.1 millimeters. And so far, what we have did, and you can see it on our 3D system, is that we performed isolation 3 out of 4 veins. So right superior, right inferior, and left inferior have been isolated, and this is the results of the remaps. You can see this lesion sets, and you can see silence in the 3 out of 4 veins. Only left superior still has signals.
Can we see bigger screen with these maps? Because we see now just your team.
Can you go to single view map? Single view, Ante. Can you go to single view? Okay, single view.
Just a single view, just to show what we have done. So single view on a 3D system, please.
Good. So yes, I put it, but you don't see that.
Okay, so I hopefully we don't see it, but I hope that you see it. And you can see that the left posterior wall is spared by the ablation currently, but the plan is also to perform posterior wall isolation as well.
Good. Okay, so we are ready to take off. So we have performed the right-sided veins, left inferior vein, we remapped, and then we're ready. We have circular stellate inside, you see on fluoro. So we have 8 electrode circular stellate, circular catheter with circular stellate. Now we drive our catheter to the left superior, and I will annotate which segments I'm ablating. So this is left superior, watching from the internal. This is anterior, posterior, and inferior for the left superior. You see the signals on ARGA 1, 2, signals are still there. So vein west haven't been isolated. This is LSPV, pulse 1, go. So the idea is to deliver 6 applications. Each application is at 13 seconds. We guide our application by fluoro, by ice, and by this case, Opal HDX system. And the idea is really to cover. So now I'm able, now you see the catheter recovered, and now I can rotate the catheter, let's say here, or I can do counterclockwise rotation, whatever suits my purpose. So now the patient did some cuffing. And of course, as soon as we have cuffing, because we are using impedance monitoring, there takes some time to recover. Here, this is posterior, superior, anterior for the left superior pulse 2, go. You nicely see on eyes that we are just at the ostial
How do you judge proximity?
Proximity of what?
To the tissue proximity with the catheter.
So currently we can visualize only impedance-based proximity and operate here. Sorry, this is posterior, superior, anterior for the left superior. Go, pulse 3. So now we can show you we can light up. Ante, can you light up the impedance proximity index? But also the console engineer, the generator engineer can show you post-ablation about the quality of the contact based on the, obviously, on the impedance. I'm counterclocking now. Good. So this is superior, posterior, inferior for the left superior pulse 4. Go. So currently, obviously, it's not seamless integration in the system. There's no prospective contact feedback. So we have to use multimodality imaging to realize where are we touching and where are we ablating. Obviously, the contribution of a 3D mapping system is crucial. This here, good. This is superior, anterior, inferior for the left superior, pulse 5. Go. This is the last, this is the, so the next one will be the last pulse of LSPV. And as soon as we are done, we're going to change the stellate from circular to linear and continue with the superior wall
Posterior
roof line.
wall.
And then, good. And then the last line, I will do I will do slightly more antral here. I like it. So this is superior, anterior, and posterior, inferior for the left superior. Last pulse to left superior. Go. After this lesion, now we change to linear stellate. So I don't exchange the catheter. There's no exchange over the sheet. So definitely reducing the opportunity for air ingress.
So that vein is finished. That is very quick.
Now we're done. Usually now let me come back with my catheter in a Gillis. I'm extracting circular. I'm taking linear stellate. And now with extracting after this, we are ready to go with our linear lesion on the roof. So the next stop is the roof line. And we'll be flexible. Depending on the position of the catheter, we'll select the electrodes. So catheter exchange, I go back. And now what I want to do, I want to anchor for the roof line. For the roof line, I'll try to anchor my catheter. So catheter goes up. Let's say here we see that we are, let me see. Yes, you see we are in left superior, but the next move should be like this, something like this. Catheter is loose. Let me try now. Oh, good. It's a good contact. Do you see now, guys? We have pretty much good contact. Now, can I visualize catheter? Ante, I need catheter visualization. We changed from linear. Antonio.
Is it on the mapping as well? The non-fluoroscopic mapping?
Yeah, so
It should be.
So you see here, so what I can do now, based on ice, I can really treat the first portion. I would say the lateral portion, good contact. We're going to do back 4 max. Guys, you see this?
Yep.
Back 4 max. You see good contact on ice.
Back 4, wait.
Back 4 max. You see good contact?
Yep,
Look,
we
fantastic footprint. As soon as you program, we're good to go. We do back 4 max, go. So in this way, we are using the distal part of the catheter as an anchor. So 1, 2, let's say here, 1, 2, 3, 4, I use them as an anchor. You see?
And you turn on the other 4.
Yes, so 1, 2, 3, 4 is turned off.
Yep.
It's deep inside the vein. We don't need ablation there. Yep, okay. And what we're gonna do now, we're gonna configure just to deliver from 5, 6, 7, 8, and we're gonna do the max. Max lesion is gonna take a while. So it's gonna take closer to 24, 25 seconds. But the beauty of this max lesion I discussed in the lecture, that I can really go deep as deep as 1 centimeter. And you know, if you have a young male patient, athletic, I think we all appreciate it's not easy to transect the conduction across the roof, especially across the septopulmonary bundle to the central part of the posterior wall. This is why we opt for the most of the time to do this. I see on eyes that it's not super flat roof, so we're going to apply the second application also. And okay, our engineers are configuring the generator. So please, as soon as we are configured, back 4 max, I repeat, go. So now they're configuring the generator. So you see how nice is the footprint. Due to this footprint, we know we are in contact. And when you're in contact with this generator, trust me, this lesion will be durable. We know from the animal lab data. And then we could choose also to use here like a phasing to alternate between the electrode and between the electrode and the return patch. This is something that we can do. However, here we get 4 max go. Now we are firing 4 max. You see good contact during ablation. Essentially, we are really ablating where we want from. You see, back 4 electrodes are right, extending from ostium to the central part of the roof. It could be, you see on the map that we already have an overlap. It could be that we are done. However, let me, for the durability purpose, because this is ECAM workshop, Prague workshop, I really want to share next year. I really want to share the remap from this patient. So we're going to apply one more lesion, but this time after this, we're going to anchor our catheter in the right superior.
Is this
Done?
bipolar?
Okay, retracting a catheter.
Bipolar lesion?
This was bipolar, yes. So here, you see this? Now, let's try and see how can we bring this. You see now, I can do double line. Let's say, Tony, thank you. So now I can fire 2, 3, 4, 5. Because I believe 2, 3, 4, 5 are in contact. 2, 3, 4, 5 max, go. Fantastic. Tony, I think you appreciate that the central part has a good contact. After this, we're done. And then I'm going to go in a 1, 2, then we go stay in the linear. We're going to anchor it in the left inferior. Once we anchor it in the left inferior, we're going to probably do 1 4 standard because we don't need really 8 millimeter depth there. So we're going to do 4 standard. And then we're going to continue with focal ablation to isolate posterior wall.
Ante, can I ask you?
Sorry?
Can I ask you, why don't you use this circular catheter to cover the whole posterior wall? That would be easier than doing these linear lesions.
I mean, we tried. Let me tell you, we tried, but I don't think it's a perfect, I don't think that the linear is a perfect way here. Okay, guys, now let me push. You see again, good contact of the wall. What I'm going to do now, sorry, so 4, 5, 6, 7, please. 4, 5, 6, 7. I'll repeat, 4, 5, 6, 7 standard. Yes. Let's go. So you could do circular, definitely. But I think it's really nice to spare some myocardial cells at the middle of the wall. And I think this is more appropriate. It's so easy to isolate with the linear application. And now what I'm going to add, a couple of nitro. Please go nitro. And now I go to the, so now I just connect the rest with a focal. Good contact there. Can I visualize the catheter? Focal, Ante? Focal 1, 2. So now we switch to focal ablation. So we're now going to do just bipolar ablation between 1 and 2 electrodes. I need 1, 2 visualization. Antonio? Just wait for our arrhythmia guys to switch between visualization. Again, not a seamless integration is the best. Tony, I think we have a good contact. Yep. And for the bipolar business, it's good that we are almost, linear or parallel to the tissue. Okay, now I'm waiting for the catheter visualization. I need 1, 2. Sorry, guys, if you have any questions, go on. We already applied nitro. You already applied nitro for the CTI?
Yep.
Good.
It's in.
Thank you, Tony. Now they're changing. Yes. So let's start. Ante, again, we're going to use, remember, we're going to use 8 millimeter tag, Antonio. Let me see contact. Good contact. Point here. 1, 2 standard. Go. So what I need is it 8 millimeter tag, Ante. 8 millimeter tag. Please check it's 8 millimeter tag. Okay. Okay, now let's go to the right. Let's go and finish here because now we have to anchor it. Let's see here. Okay. Antonio, point here. Show me contact. Good contact. Go. And then 1 in the middle, I think will be good. Good contact, stable catheter on ice. You see on fluoro, we are just finishing the inferior line. I guess the posterior wall is already isolated, but I really want to put another lesion. Okay, let me put one more lesion here to really anchor here. Okay, Antonio. Just here. Point. No, wait. Point. Go. Good contact there. So we get approximately 1 centimeter wide lesion here, and it goes it's at 3 or 4 millimeters, still 1 centimeter. Now, I want to do high output pacing from posterior wall. I'll drive the catheter to the mid posterior wall. Guys, I'm driving our catheter to the mid posterior wall, and let's see if we have isolation or not. Okay, Ante, we'll do. Okay, Antonio, are you sure that 1, 2 is a, no, unfortunately, 1, 2 is not a signal. Do you see 1, 2? 1, 2 is not a signal from a 1, 2. I'm in a vein and it's not realistic. Ante? Signal from 1, 2 is not 1, 2. Can you high output pace 1, 2? We're touching posterior wall. We are pacing 1, 2. However, only the signal is bad, okay? No capture. Good. Let's switch. Let's switch. So no capture here. Let's switch to CTI ablation. We have any questions here?
This is more like a box lesion.
No, it is.
Okay, so now I'm
box
moving.
lesion, yeah.
Now I'm moving. Okay, good. So now we are moving for the. Now we are moving toward the CTI. You see, it's a very specific maneuvering because I want to get really catheter like this over the CTI. Tony, sorry, a moment. I'm probably more lateral. Let me go more septal. Tony, now you're going to visualize me. Look at this. Now, I like this position. Tony, look at this.
I'll show you.
Very nice position, very nice contact. And can we see the catheter? I would say, Tony, can I see? Can I rely? Look, I would say, can we do max from 7654?
How long is this array of
7?
electrodes? How long is the array of electrodes?
6 millimeter spacing. 6 millimeters is spacing.
No,
So
but I mean
4.8
the whole
centimeters.
coverage of
4.8 centimeters.
the catheter by electrodes.
Yeah. 4.8, close to 5 centimeters. Okay, this is CTI. We applied. We like a position. This is CTI. We have 4, 5, 6, 7 max. Go. So now we are ablating CTI. Go. Nice position. I'm gonna do more of the. Yes.
And this is the preferred configuration, candy cane.
Yeah, so we can use anything. You see that we are configuring based on what we see, on ice, and based on what we see on. Get ready for CS910 pacing, and let's see if we have first pass bidirectional block. So I'm going to drive after this lesion. You see some PVCs because we are ablating the tricuspid part of CTI. Let's see if we can get. Sometimes we get first pass bidirectional block. So let me drive the catheter toward. Look. Just a moment. Let me drive the catheter toward the. You see now?
Yep.
So
Lateral.
if I pace CS910, and if Arga 1-2 is the latest, yes, you see, Arga 1-2 is the latest. So we have first pass. Can you pace Arga 1-2? Arga 1-2. So we are pacing Arga 1-2, measure towards CS910, and then pace Arga 5-6. Okay, this is 140. Measure pace Arga 5-6. Measure. It's similar. Okay, good. So it looks like I can even get closer. Can you now pace our Arga 1-2? Arga 1-2. Measure. Now you see it's 150 something because I closed the line. So we can have block. I would pause here and I'm ready to field question because we're going to do more in CTI. We're going to do more focal lesions, something like that. But we are done with the case showing. Ready to receive question.
Okay. Any questions? There is one question.
We wanted to show you a lot, but that's why we're quite quick.
Thank you for the case, very interesting. I have one question about the configuration of PFA for isthmus. Do you apply the same energy as in pulmonary veins? And why does it function? Because we have like quite different tissue, what we ablate. Do we have same results for CTI as in PFA in terms of long time isolation?
Yeah, so so here you saw several applications. First off, for the PVI, we use mostly 8 electrode standard nominal dose. The nominal dose takes 13 seconds, and the depth you get is around 6 millimeters. We applied 2 applications in the roof line, one anchored in LSPV, one anchored in RSPV, with 4 electrode max. That takes around 24, 25 seconds to apply, but that gives you close to 1 centimeter depth. Then we applied 4 standard, anchored in the left inferior to take lateral part of the inferior line of the posterior wall. And that's the same standard application as nominal dose for the PVI. And then we applied 1-2 standard. We might have applied 1-2 max, but we don't need focal max for the posterior wall. It's just 3 or 4 millimeters there. So we do 1-2 standard, couple of focal applications. In a CTI, we again use max because, with CTI, you care about the tissue. Sometimes it's very complex. The architecture, it can be thick. And of course, the contact is not always super stable. I was satisfied during application. Was satisfied with our contact here. I might leave things like this, but I will apply several more applications, focal applications, to reinforce this in a CTI. So no, we are not applying the same dose. We are adjusting the dose based on what we are ablating.
So this isthmus was relatively easy because it was more or less flat. But sometimes you have some deep excavations. So then you use a focal, or how you cover that?
So please look on ice now. Look on ice now. Here I am. If you want to give more septal, you see contact?
Yeah.
I'm there. You see, so if I want to address, and this is very important, thank you for asking, not too many multipolar platforms can really address those pouches, because pouches are always there. If you go septal, always there is a pouch. And in 30%, there's extremely deep pouch. So now we're going to do more, because just to address those pouches and maybe to address more this tricuspid segment, that's it. Thank you for the question. So you see how fast you can reconfigure our setting.
More questions?
That is impressive for the CTI. Do you need to reinforce it?
I will reinforce. Okay, guys. Okay. For the purpose of this meeting, I will leave it like this, and in 1 year I have to report durability. Okay? Fair?
Okay.
Very fair. Very fair.
Fair, because this patient will undergo remap. They have to remap. I'm going to reblade. I have very good feeling about leaving this CTI with a single application, and we're going to remember the lesion set, and we're going to report next year to Professor Kastner. We're going to report the durability. Okay, fair. We're done with the case then.
That's excellent. Well done.
Thank you very much.
Great case.
Thank you.
Thank you.
Thank you. Bye bye. No application. Catheter out.
Okay. Can we move back to Homolka? We should have a report or update of the previous case, and we should have a pre-recorded presentation.
Perfect. Okay, so Peppo, can you hear us? Okay, we are back, right? Okay, so you can see on the carton maps right and left. Okay, as you can consider, right is the baseline. Okay, right is baseline, and left is after the several applications, like nominal 8 per vein and the upper veins bonuses. You can see that, well, we really avoid too much narrow. I always worried about narrow isthmus on the left posterior wall. So actually, you can see this very nice post map. So,
and Peter, just one thing. I just got a summary of this case. PVI duration was 16 minutes, and flow time 10 minutes, and we did 48 applications for 4 veins.
Okay, 48 applications is something we are not even considering some hemolysis effect or whatever. And actually, I think that it's very nice to show how fast is the learning curve for this. As I mentioned, this is our 3rd case here, and this learning curve is very, very fast. So, but now, the last thing before my recorded case, I really want to show the anchoring principle. So you see the VAR and the flora. VAR is highly deep in the left upper, okay? And if you consider the catheter pulse select catheter is in blue, okay? So it's live. All other catheters are shadowing, okay? So I go like more posterior and I pull the catheter back, and actually you can see that I can play with the sheeting all the aspects of the posterior wall. So actually, if we have a persistent patient, persistent AFib patients, I can easily put with this anchoring from even left or from right side, I can cover the posterior wall, okay? So this is the aspect, I think that it's clearly could be done, and we did it actually in one patient, okay? So if no questions, I need to just move and jump to my recorded case. Can you give me 1 second, okay, to move there?
Wait a minute. Is
Okay,
there any
yes.
question towards
Yes, questions.
for Peter for this case? There is one question. Okay,
Please.
ladies, can you? There is a question back there.
Okay, nice. I see the nice lady coming with the mic.
Did you perform one transeptal puncture or two transeptals?
Single, always single.
Or put in the echo?
But you know, when you have this just 10 French sheet, so introducer, you can easily go. So what the trick for inserting the eyes is you leave the wire from the pulse select catheter in the vein in the left. You pull the sheet and the catheter back, and then over the wire, actually over the wire. You can navigate with the wire and the visualization by eyes itself. You can find a hole and you're going easily to the left atrium. So we are using, actually for all these technologies now, actually I don't remember when we did our last double transeptal. Okay, so single. Single answer, single.
Okay, any other question?
Another question. Yeah, thank you, Professor. This is more a general question. I would like to know when you perform posterior box isolation, you rely more on atrial size, you rely more on AFib duration, you rely more on bipolar signals, and if in bipolar signals, you study the bipolar signals during AF, or you cardiovert the patient and remap in sinus rhythm, and then
it's a very important aspect. It's a very important topic you pick up. The question about posterior wall. Okay, why we are doing this pulse field posterior wall? Because we can. Okay, it's safe. And actually, until now, maybe for sure. So the manifest trial showed, the registry showed, when we compare the posterior wall and recurrences. So, manifest PFA trial didn't show the bonus from the posterior wall. But actually, we need to consider with PEPA the aspect who did the posterior wall and which way, and how is controlled the posterior wall application. So when you have no navigation, actually it was fluoro system only, so fluoro procedure only. Or if you have no eyes, you cannot control the contact. So I think I wouldn't like to rely on the manifest data at all, in terms of posterior wall, but it's good decision to get either like persistent patients. I really want to show conversion. So we never going for cardioversion after PVI. When we decide to go for posterior wall, we try to get conversion by ablation itself. But I'm not relying on the potentials.
I think if I can add something,
yes,
I
please.
share the same now experience that before I never did chase AFib until it will stop. I did some lesions and then I cardioverted the patient. Today, with Varipulse, I can terminate practically all AFibs, which are persistent. Fantastic. Or even long persistent with some extensive ablation. But this is not proof that it's really working. So we are running in Czech Republic 3-center trial which compares in persistent patients, which compares PVI only versus PVI plus posterior wall plus mitral isthmus. We may discuss whether mitral isthmus is the optimal strategy for this technology, but I think it works better on anterior line, but nevertheless, that's a randomized trial, so we will have, I hope, next year the results of this trial, because as I mentioned earlier, we have to redo all these trials, couple of trials. It has no meaning now, because with these technologies, you change completely all business.
This is an important trial, different modality, so we need to reaffirm what we think we know. I agree.
Actually,
How many patients in the trial?
Can I add something, guys? Can I add something to this? So actually, we have the FRAPulse sessions afternoon, right? So we have 4 cases for FRAPulse. So we can stress how is optimal shape for doing the CTI isthmus line or CTI isthmus ablation later. Okay, so I think that we can stress and we can save the space for talking for the FRAPulse. If you don't mind, if you know any other questions, I will jump to my recording case. Is it okay?
But be careful not to break your leg if you are jumping.
Yeah, no, fine. Thank you. Oh, look, Pepa is like my father.
So we will have pre-recorded case of globe ablation, and that's it. We can spare some time, hopefully, for coffee.
I'm back, guys. Can you hear me? Yeah, perfect. Okay.
It was fast jump.
I have a good legs. Look, where is it? Here. So nothing happened.
Very fit.
Okay, perfect. Okay, so I will run. Okay, so this is, I have no introduction slides. Actually, it's like persistent patient, persistent atrial fibrillation patient. We did through the case through this Pulse EU trial, and I will start now the playing. Okay, so let me start the movie. Perfect. Okay, so as I mentioned during my presentation, the prepping of the sheeting is very important. So if you consider, I will stop for a while, okay? So if you consider the sheeting is here, okay? The surface is very nice because the hydrophilic is going very nicely there. And even it's like, ID is like 12, but it's like 16 French, OD, and actually it's really nicely inserted when you have prep. This backward system protect you to aspirate the air to the sheet, and this knob is helping to angulate. So we have one deflection. You have one deflection on the sheeting. Okay. So I will try to run again. So we are inserting just the introducer with dilator to the left atrium, and you can see that we have a wire in the left atrium. Actually, we are using super stiff, like extra stiff, not like SL wire or this transeptal wires, but we are using really super stiff, extra stiff wires. Now we are facing, the dilator is already facing the septum. Now we are inside with the sheet, and now we are ready to go with the system inside. So you will see in a minute. Okay, now we are ready here. Okay, now we're deploying the catheter. Okay, look at that, that's eyes. Okay, this is deploying the catheter. We are always using eyes to deploy safely. Okay, we can see on the floor as well, but this is critical. So we need to be in free space with the hack, and actually when we started to insert, so then we can control even angulation to be in the free space of the left atrium. Okay, so now we need to connect. The system. So with the console and with to be able to apply the energy. And as I stressed during the presentation, whenever you open this 30 millimeters basket, whatever globe catheter inside the body, you can immediately get some information. Okay, so highly valuable voltage information, highly valuable every other information like activation, whatever. So what is very important to indicate just briefly where is the orifice of the veins to build up the body. And well, here you can just see that we are able to indicate even like appendage orifice. And this arrow indicates the orientation. But actually, I didn't mention during presentation, whenever you are facing with the globe, what is the axis? So it doesn't need to be coaxial, okay? It doesn't need to be coaxial. This is activation map now, and you can see this activation during this running arrhythmia, and actually you can see that the catheter is really able to get you, because of 122 electrodes on that surface, it give you a lot of information. Okay, so let's proceed more. Okay, so now I will show you this the principle how to get closer to the veins and how to get the flow map and the contact map. Now it's like contact map here. You choose these elements to application, and you can see that it's like 3 veins in this particular patient, so like middle vein as well. So we try to get as much as we can, and now it will be pulsing. Okay, now it's pulsing. And we are using 2 types of pulsing. Now we are short, like 15 seconds pulse, more or less. And now after pulsing, you have immediately information, not about the potentials, because, well, you have voltage information, but we can discuss how predictable is the information. This is a pre-contact scan map, which is very, very important that you can be really in good contact, excellent contact, I would say, and you can visualize the orifice or actually orifice of the vein. So I will move up, and actually constantly you have a good indication what did you apply. So actually you can indicate the lesion set. Actually you are actually we want to minimize the applications to get this really like single shot. So actually we prove that in one position, if you choose the good contact quality, then we are able to really isolate the vein by one application. Okay. Okay, I will move up. Okay. So this is the other side. So like we finished with right, so we are now left. As we covered the right middle, right inferior, and now on the left, look at how big contact you have here, right? So it's a huge contact on the left inferior, left superior is done, with the lesion set indicating by the pink color. Then now again the pulsing, and after pulsing, you can see again these voltages. So to indicate to move it faster. So we try to get, because of persistent atrial fibrillation, so we really, and we stressed during the presentation. So we were very valuable to get the posterior wall and the contact, and you can consider how many elements you are in the contact when you push. But don't like complain about the anatomy shape, because you really deviate the borders. Okay, so it's not representative anatomy when you push, but you need to push to get the contact. Okay, so well, it's like you need to be balanced. But somebody asked me about how many applications we are redoing on the posterior wall. So it's always like around like 4, 6. I don't remember if we have more, maybe like 8 applications per posterior wall. So when posterior wall is finished, then we have actually, as it is like good mapping system or as well. So we are able to get all the voltage information. If you like to see that, fine. So we have all this like posterior wall and PV isolation comparing okay, here. So now we are moving to the right side. So we need to pull the catheter out. So the mechanism how to pull it is a little bit like you need to play with the sheeting, and you can see here in the both flora and eyes the maneuvers how to get out. So we are getting out safely. You don't need to hug with anything. There's a tissue and it's going even inside. So now we are ready to go to the CTI. Now we are in the right atrium, and you can use, and actually it's highly valuable to have again eyes for getting good information like topography of the right atrium and isthmus itself. And again, the same thing, the same principle to get a flow map, good contact. Based on the contact, then you can choose not just full area. So you can choose really like dedicated lines. So you can create with even this bulky basket, you can create really distinguished, very narrow line of isthmus block. Okay, so this is actually, I hope here the operator is changing. I think that Vivek is there. We were like with Toshi there, so it's always fun to do these cases together. And actually, you can indicate your lines. We did, and actually, I will go very close to another application set. So we really want to cover, because it was pretty long isthmus here in this patient. So we did really more application, more like longer line, and then hopefully in the end, I don't remember. Oh, here. So So we indicate. Okay, sorry. So we indicate. I will briefly stop when we have this. Pacing, and actually we really try to get. I really get up here. So then we can map and we can just validate. Okay, and you can see even the splitting here, the potentials by one single basket, and actually even this activation indicating the block. Okay, here and here. Like look at this distance. So it's perfect, even for very simple, very fast. Sorry, I miss pulling the cutter, but you saw that from the left. Okay, so I will run it again. So. Okay, it's very important. Even on the right side, it's more important to take it out safely. And now we are back and we finish the case. Okay, so guys, I'm finished with this. So if you have any questions, I am more than happy to answer.
So questions? If I may have question,
Yes.
on left side, left superior vein is often very flat. So basically with this ball, you just
yes.
Somehow push it against this against the ridge between appendage and vein.
Yeah.
And
So
you are not inside the vein, but just
yes.
pushing to the roof, yes?
Yes, absolutely. But it's always nice to tilt a little bit more anterior, because if you apply the force, it's going more posterior than you need to. Okay, so you need to compensate. Okay, so always, but as I mentioned, the orientation of the basket is not. So you can apply in any shape, any direction, You don't need to be coaxial, okay? So we're, as a conformal, like yesterday, when you want to close the appendage, this is a little bit similar. So you can just orient the basket whenever you have contact, you apply, you can choose the elements, and so it's not based on the orientation of the basket.
Peter, it's Paul Gould. A very impressive case that flowed really very well. How did you know there was a right middle vein? Had you done a CT beforehand? And how do you set the
Actually, you know
veins
what?
up?
I am afraid that we haven't had any CT. Actually, it was indicated by a little bit like eyes and more or less eyes. And actually, you can visualize actually even on the globe system when you have too much holes, okay? Because now, as I mentioned, the black hole is like the non-contact means like if you can see like three individual holes. So okay, you need to consider something either branching or individual. So then we focus with eyes, and actually it was based on eyes.
Thank you.
In this case.
If
But you
there's
can
no more
see that
question.
on
I
the
heard
globe.
that Vivek has some presentation, so can we move to his presentation?
Okay, give us some minutes, whatever, and we will be back with Vivek. Actually, well, we have some kind of issues with the field, so I don't know, I have no information. So guys will let you know what's going on, okay? So give us like 1 second. If you can discuss, you can get for discussion, but we will be fast back, okay? Please.
Thank you.
So we will have one more presentation in these cases. So
is one more presentation?
Rotate down a wee bit.
Vivek?
Yeah. Oh, hey.
We can hear you, see you.
You can hear us? We're trying to figure out what to do. So, hi everyone. We have a bit of a technical issue, and we're trying to decide whether to torture you with what we're seeing or not. I think we will. Let's just try, and then we'll show.
Let's try, yeah.
Okay. Okay. So we can. So we have a patient who has paroxysmal atrial fibrillation, who was receiving propafenone, also has some flutter, and she's enrolled in a clinical study using the Field Medical focal ablation technology. This is the one that we showed yesterday for VT ablation. The problem that we're having is we're having some technical issues. It's actually not related to field, it's related to the cardio system. We've been troubleshooting for the past, I think, hour and a half or 2 hours. So unfortunately, and you can sort of see that there's some flickering here. I'm not moving, by the way, the catheter. It's just dancing, and as Melanie said, it's twerking at times. So we don't really understand that there's some noise that's been occurring even when we unplugged everything except for the cardio system. So unfortunately, I think you're going to have to see how we do the procedure and just sort of imagine what it would look like if it didn't have all this motion, okay? So let me show you what we have. On fluoro, what you're seeing are a couple of catheters. We have a transeptal sheath. This here we're using an Agilis sheath, 8.5. This is the ablation catheter itself. You can see it there. It's a bidirectional deflectable catheter that you see on fluoro. You have a CS catheter, obviously. It's a decapolar in the CS. And then we have an octave. The octave is just sitting in the right atrium right now. So we put the octave catheter in the left atrium, created mapped the matrix, the ACL, and then we isolated the left pulmonary veins, mainly because we were trying to see if this is going to be okay. And now what I'd like to do is to show you isolation of the right pulmonary veins. What are you seeing up there? Okay, good. So you're seeing electrograms. You're seeing, do they see the, yeah, okay. And you're seeing the ICE image too. So what we're going to do now, I'm going to take the catheter, move it to a location. What you can't see is there's also a force sensor. The force information is not integrated. None of this is in it. The catheter is not integrated to the mapping system. So the force sensor information you're not seeing there, but I can see it off screen. So the force sensor uses optical fiber, and we can tell that we have contact. It's sort of a, yeah, anyway. So I have contact at this location. You can see the electrograms on, can they see the electrograms on PRAGUE? Yeah. So you're going to see the electrograms on PRAGUE. Actually, you know, on the Biosense system, you guys just hide all of the octave catheter electrodes so they can only see the ablation, because I think that's what, yeah, you can see the ablation catheter there. What is E1 for? You can hide that also, we don't need that. Okay, good. So you see the ablation catheter there, ablation electrode. Now we're getting more location and fluctuation. Okay, because it's not integrated, the way we do this is once we feel like we're in a good location, we're going to click one of the points over here that we think we're at. Oh my God, look at it, it's getting worse. We're going to click one of the points. We're going to call that an ablation point. We have to turn off the magnet, do the ablation, and turn the magnet back on. Okay, it's a little bit of a clunky workflow, but let's just get going. All right, Chief, let's. Jesus. Okay, let's take that point right there. Okay, hide, magnet off, ablation. So that's the ablation. I'm not moving it. You can see the electrogram has disappeared. Now I'm going to move down to what we think is the next location. Point, hide, ablation. Okay, next. I'm going to move down again. Oh, Jesus Christ. Okay, take a point there, please. Hide, ablation. Okay. I can move down further. Point, hide, ablation. Okay, come down further. Okay, point, hide, ablation. Okay, let's go here. Take a point, hold on. Okay, point, hide, ablation. Okay, let's go, hold on. Okay, yeah, I like that. Point, hide, ablation. Point there. Oh, no, hold on, wait. Yeah, I like that. Hide, ablation. Go RAO, please. Yeah, thanks. Okay, let's go here. Oh, hold on. Okay, I like that. Point, hide, ablation. You know, I don't know if that, rotate up for me. Let's just do one more. I have no idea if that's real location or not. Point, hide, ablation. I'm doing a few more lesions than I normally would because I just don't trust the accuracy here for the obvious reasons. Point, hide, ablation. Okay, hold on right here. Point, hide, ablation. I'm paying, unfortunately, you guys can't see the force information, but every time I go to a location, I verify that I'm actually touching something.
So Vivek, it's Paul Gould.
Hey, Paul.
How you doing?
Good,
what
good.
parameters do you go for the force?
Well, so right now the force is, it's actually a numberless thing. It's not actually calibrated yet.
Okay, so it's all
I know is I have
binary.
contact point. Yeah, you know, unlike radio frequency ablation, I think what we care about is tissue contact. Frankly, what I really care about is tissue proximity. Point, hide, ablation is tissue proximity. So as long as I'm touching tissue, I don't really care much beyond that.
So it's a yes or no proximity indicator.
Yeah, exactly.
That's good.
It actually has more point, hide, ablation. It's just that right now, what we can trust, ablation please, what we can trust is the fact that we actually have contact or no contact. Eventually, it actually is going to give us more information. Point, hide, ablation. It actually is going to give us more information. Show me REO one more time, Chief. There's one location. I don't know if it was real or not real or whatever, but I just want to put one more lesion here. Okay, point, hide, ablation.
Very quick.
Yeah, this is actually, now you can imagine a situation where it's not so clunky. By the way, it's isolated. I didn't really show you, but we can put the catheter inside. What we'll do is we're going to switch and put the octave and map. While Honza does the mapping here, I want to show you what this should look like, okay? So I'm going to go there, and then we'll come back. We still have to do a flutter line, actually. So we're going to show you a flutter line right after this. We still have like 20 minutes, right?
Yeah. We have,
okay, perfect. So let's go. So Honza, you're okay?
Yeah, I do
okay.
the map. Yeah,
You do the map for me. Okay.
Can you
So
just play
what we're going to do now is let's look at the let's show the flutter. Oh, no, not the flutter. We're going to show you Can they see me here? Yes. Can they hear me? Okay. So right now, can they? Yeah, perfect. Okay. This is actually a recorded case, and I'm just going to play it. So this is going to be playing in real time here. Oh, what just happened? Okay, this is going to be playing in real time. So nothing is sped up here. There's a point here. That's the ablation. Again, the workflow is a little bit clunky. It's a little bit clunky, as you saw, because, well, again, it's not really integrated. So we're clicking. We identify a point where we think the catheter is sitting. So, for example, there's the catheter. Bring it down here, and then you see that we take a point, deliver the pulse. You just see that flying past really quickly. Then move to the next location, etc. But notice here, now this again, I have no idea why we're having this location issue, and it's actually a CARTO issue because even when we disconnected everything, just the octave catheter was flying around. So anyway, but most of the cases go like this. I'm just going to let this play. And as it plays, hopefully you get a feel for what the workflow is.
It's
This
presenting
clock,
well,
by
the
way,
workflow. It is.
What's that?
It's presenting well, the workflow.
It is,
Even with the problems you had, you went around that vein very quickly. How many trains are in the each delivery?
Yeah, it's so I don't know any details. I can only tell you what I know, which is the whole pulse is QRS synchronized, and it's delivered in less than 200 milliseconds.
It's so quick.
I mean, that's it, right? It's just it's like a snap of a finger. And what's really exciting about this, this sort of instantaneous ablation, is that you can imagine a situation, which we don't have yet, right? But you can imagine a situation where, let's say, the catheter is integrated with the mapping system, right? It actually has a magnetic sensor. It's just not communicating. But let's say it's integrated with the mapping system. Then you can imagine a situation, the operator is moving the catheter. As they get close to the location, the system senses contact and just delivers on the QRS. And then you go to the next. It's like how we used to do drag lesions.
So automatic,
yeah, automatic. Again, we don't have that going yet, but that's the next step.
You can certainly imagine it. It's extremely quick.
In my mind, this is the future of atrial point-by-point ablation. I think that, sort of regional ablation catheters have a role. I think point-by-point has a role. And in my mind, there's little doubt in my mind in 3 to 5 years, point ablation in the atrium is going to look like this.
So Vivek, the animal data, how deep are these lesions? Because it's just so quick.
Yeah, so the preclinical data indicates that the lesions will be about 5 millimeters, maybe 6 millimeters deep. But what really matters, of course, as we all know, the animals, the data always looks good, is what happens in patients. So I should note, this catheter does not have regulatory approval anywhere in the world. We're doing this case, obviously it's a live case, but it's also, the patient's enrolled in a clinical study called, I don't know what the name of the study is, but it's called something. And it's the first in human study to use this catheter for AF ablation. So this clock, by the way, that you're seeing was the time from the beginning of the first lesion. It's just going to run through as we finish isolating this side, and then we'll go to the other side in just a second. I don't know why I'm taking so long over here. But yeah, from a safety assessment, one of the things, I guess we didn't show the ice on this one. I don't know if you noticed the ice image in the previous, in the case over there, and we'll see it more when I go back. With each application, you do see a burst of microbubbles. I mean, it's a veritable hurricane of microbubbles.
Electrolysis.
Yeah, and we believe it's all electrolysis. That microbubbles can happen for multiple reasons.
Yeah.
The two main ones.
Is there any thermal effects?
So we don't believe so, based on the preclinical data or benchtop data. We're doing brain MRIs, obviously, in this series of patients, just to prove to ourselves that we have no silent cerebral ischemic events. So that's an ongoing, it's an ongoing project, obviously. Yeah, we feel confident enough, obviously, that we're continuing to treat patients. So, you can take it for what it's worth. Yeah, and then here, again, we're going to go to the right side and start isolating. In terms of safety assessments. PV stenosis, we're not really worried about. Obviously, that we're going to assess this. The esophagus, the data looks just like most of the other catheters. I talked to you about the brain MR imaging. What else?
Vivek, just one other question, just a little bit of segue. What do you think about this for, say, slow pathway or accessory pathway ablation?
Yeah, I think that, look, one of the things that we have very little understanding of, certainly with this catheter, but I would argue with all of the PF point ablation catheters, is we don't have a good understanding of lesion size as a function of energy delivery, right? So we need to have just, the simple sort of dose response curves of if you deliver this dose, whatever that means, whether it's amplitude or duration or whatever, what is the predictable lesion size?
Human data, yeah.
Yeah, and so we don't even have good preclinical data for most of these. So, you just get, here's what you get when you use the nominal dose, right? We don't know what happens when you use less or more. So I think that these kind of catheters are going to be great for most focal arrhythmias or focal ablation. Maybe not AVNRT, but for most of the others. And I think that it's just going to take some time. Right now there's a race by most of these companies to try to optimize their waveform so they can get a good atrial lesion for AF ablation, because that's the market that they understandably are chasing. But I think eventually we, the EP community, will have to sort of understand the dose response of these things to do what you're suggesting or asking. So, in the interest of time, let's see how much time we have left. 15 minutes, that'll be enough. So I'm just going to skip forward here because you just saw me isolate the right side. And what you'll see is, let's see, yeah. So look at this. So we're at 9 minutes and 10 seconds in this case. So that's both quick. The left and the right? Yeah. And honestly, this is still a clunky sort of workflow. Once it's fully integrated, you can imagine this routinely taking 5 to 7 minutes to isolate the veins. And of course, the flexibility of point-by-point ablation is that you can then potentially target other things like a CTI, or let's say some of these AF source mapping algorithms, really become accepted and reliable. Then we could start using this technology then to target those regions.
And atypical flutters and ATs and line-based ablation.
Yeah.
Linear ablation.
Right. So to that point, I think what we may want to do now is, if it's okay, I want to go back over there. Honza, are you guys ready over there? I don't know if you can hear me, but anyway, I want to go back over there and let's do the CTismus line. So I didn't show it to you because we were so worried about the technical issues, but the patient actually came in typical flutter, and then we cardioverted because we're trying to understand what's going on. But we need to do a CTI line there. So let's go back over there.
To see.
Okay. Can you turn this thing on for me? Yes. Oh, okay. That's good. Okay, Hansa, are you ready? Yes. I don't know why. Okay.
Don't forget your nitro and everything.
I don't know. Okay, can you guys still hear me?
Yep, we got you.
Okay, great. So you want to show us what you did, Hansa?
Yeah, okay. So am I connected? Do you hear me?
Can you guys hear Hansa also?
Not so well.
Okay, wait, hold on one second. Let's turn you on first. Okay.
So do you hear me? Yeah, it's okay?
That's much better, thanks.
Okay, thank you. So meanwhile, Vivek had the presentation or the overview of the technology. So we created left atrial anatomy and the voltage map, and you see that we did nice PV isolation. So if you rotate the map all around, you see that everything is isolated. But on the posterior wall, there is something like a connection between both lines on posterior wall. So this is what we have to discuss later. We have to confirm if it's just a stunning for this time, or if it's real for even long period.
Yeah.
So this is what we want to prove during the remap study, because we ask all these patients to come again for remaps in 3 months.
3 month
so
remap.
this is what we don't.
Yeah.
This is what we don't now.
I saw this
I
few
should point
times
out-
with different technology, but if you wait like 10 minutes and then you remap, it usually comes back because that's
Yeah.
really
Yeah,
functional or stunning
Yeah,
or
this is-
whatever you call it.
Right. So in this case, Joseph, so there's two issues in this particular case. One of them is the inaccuracy of the localization. So there may be some issue there that we're not understanding. But a second issue is, again, these are monopolar delivery. We didn't really talk about that, but this is monopolar ablation that we're doing in this case. There's also a bipolar ablation protocol that we're planning on starting. We did a few patients, and we're going to continue those. So it may be that when monopolar, there's a bigger spread of the lesion, and it's an actual lesion. It may be that there's significant stunning that doesn't reverse during the procedure. So this is information we're going to understand better when we finish the remaps. But for now, this is Anyway, so those are the possibilities. So I think for now, let's go to the right side. I want to do a CT isthmus line. Can they see everything? Oh, can you guys show the fluoro also on the ice? Let's have them so they can see everything.
So we have also nitrates here. And
Okay, so let's do, so let's put over here. You guys see the ice image too, right?
We can see it all. It's good.
Yeah, it's still moving around. It's not twerking quite as much as it was before, but still I don't really understand what's going on with this. Okay, so now, as I said before, with every PF energy source, I'm absolutely convinced that you get spasm. I have yet to play with one that doesn't cause spasm. So we've not tested, really carefully the best protocol for this, but we're going to use the protocol that we typically use for most of these technologies. Is this a phenyl?
Phenylephrine, yeah.
Okay, how much is it?
500.
This is 500 total?
Yep.
Total 500?
Yeah, total, yes.
All right, well, I'll give most of it. So what I'm going to do, so we're ready to do the ablation. So the protocol that we use, I'll just say this really quickly before I do it. We typically give a little bolus of phenylephrine between 300 to 500 mics. And then what we'll do is we'll give nitro. The protocol that we used in the Advantage trial with Varipulse was 3 milligrams, wait a minute, start ablation, and then every 2 minutes after that, give another 2 milligrams. What we're going to do in this case is something very similar. First, I'm going to give the phenylephrine. I'll give most of it. I don't think I want to give all of it. I'll give 300 mics of phenyl. And then I'm going to give nitro also. And then let's flush. I need a bigger flush, Chief.
Yeah, okay.
Let's go ahead and start the clock, please. Yeah. Okay. So which screen is it on?
Right in front of you, the little orange box. On the fluoro screen.
Okay. I don't think they can see that, but that's okay. So we're going to wait now. So we have a clock that just started. It's about 20 seconds now. And meanwhile, I'll just position my catheter where I want. You can see the catheter on ice. I have nice force, which you can't see, but I do. I tend to bias it just a little bit lateral, just because, I don't want to hit the AV node and cause a problem. And what we'll do is we'll start ablating. So how many seconds are we at? We're at 42 seconds. Once we get to 60 seconds, then we'll do this. Where's my nitro sheet? This is the rest of my nitro?
Nitro.
Okay. Are we ready? So let's go ahead and take a point there. We don't have enough points over here, actually, to take from. All right, what are we at? Okay, 1 minute. Let's go ahead and hide ablation. Live. Let's go back here. Hide. Ablation. And then, I'll just do it this way. My sheath is actually getting in my way. I'll just use the catheter itself. Okay, take a point there. You know what? I don't like my contact now. I don't like it. Give me a second. Yeah, this is probably going to be better. Give me a second. My force is not as good. Hold on 1 second. Let me get it like this.
This is better.
Yeah, this is better. Okay, point. Hide, ablation.
Do you have to be somehow directional towards the tissue, or?
No, not at all. The way the field works, Joseph, it's okay. Take a point there. Hide, ablation. The way the field works, you actually don't need to be directional at all. In fact, when you're parallel to the tissue like we are right now, it actually ends up being very, very effective.
In contact?
Here, no, I don't like my contact now. Let's do it right here. There. You know what? Let me just do a loop-to-loop. It'll be easier.
So Vivek, when you say you don't like your contact, there are some qualitative aspects to it. Is that, do you mean from catheter position, how it looks, or?
No. Sorry. I remember the force information you guys are not seeing. Take a point there, please. Hide and ablation. I actually have a force information here that we can't put on our screen, unfortunately. So,
what number of force are you looking for? How much force are you looking for?
Again, it's right now. It's just contact or no contact.
Okay.
So it's a numberless sort of yes/no type of thing. And so yeah, I think we're pretty much done actually. Let's yeah, I can let me just see if we can. I don't know if I need any more lesions. I like it pretty well right now.
I think we are done.
I think we are. Yeah, let's just put the octray across and yeah, I think we're
Maybe
good.
this one is good, no?
You want to do one more? I can do one more. You didn't like this lesion here. Just do one more right here. Hide. Okay. Ablation, please. Okay. But yeah, so I think, and then what we'll do is we'll put the octray in. Actually, the octray is in, isn't it? Yeah, we can just put that over there. Yeah, go ahead, ablate here, please. Ablation. Okay, let's show the octray, and let's prove to ourselves that we either have block or don't have block. Can we show the electrograms too, guys? Yeah, this is blocked. Okay, let's go ahead and take a couple of points here. We're pacing, obviously, from the CS.
Yeah, that's impressive.
Take a point there. Yeah, I mean, it's blocked. We can do differential pacing and stuff, but there's a little doubt in my mind now. So,
how many lesions was that? It's only 6.
6 lesions, yeah. And you can see how fast it is, again, with our clunky workflow.
It's lightning fast.
Now, one more thing, and this is a really important point. So right now, we're at 4.5 minutes, okay? The last lesion was how long ago? Well, probably like a minute ago. So it'll be like a minute and a half. I'm still going to give another 2 milligrams because, you know, what happens is when you electroporate, all the calcium runs into the cells, right? And so you're going to end up getting spasm. Unless we give nitro. But it takes time for the calcium to be mopped up. At least this is my theory. So you can see spasm that occurs after the nitro effect goes away. So I'll go ahead and give. We're now at 5 minutes, so I'm going to go ahead and give my last 2 milligrams of nitro, even though I'm not planning on doing any more ablation, just to compensate for the ablation that was done, you know, a couple of minutes ago. So now we're pretty much done with this case. Yeah, I think we're happy. So, as I said, this is part of an ongoing series. You know, as you just heard from Honza, we have to remap. We need to understand, you know, I think the durability of the veins, obviously, you know, that's very, very important, of course, and I'm actually not so worried about that. But I think we do want to understand, you know, what is the breadth of the lesion, how wide, because that'll affect how we think about how far away we should make these points. Like right now, we put those points pretty close together. Probably we don't need to be that close together. We do it this close together because, well, for 2 reasons. 1, just to be, you know, safe. And 2, because that's the biggest red dot you can make on Cardo. You can't make a bigger one. So that's the one we use.
Thank you very much for this presentation. Any question? If not, I think we will have a coffee break and reconvene after for some other presentations on different strategies.
Thank you so much.
Thank you.
Thank you.